please. So if you can't hear me, say something in the back. Oh, come on. All right, I'll do my best. As you can tell, I really don't work for a living. I'm too busy paying dues to all of those organizations. So the disclaimers, I don't owe anything to any drug company. I walk funny because of the VA's attempt to fix my back. My lack of political correctness and the accent is from the East Coast. That's all right, you're missing the good lines. How's it? We're going to do our best with this. That's terrible. I'm not going to repeat all that, so I'll have to check with your colleagues later. Having said that, the whole field of geriatric care, physiatry, elder care, I don't have to tell you while you're sitting here, has really exploded in the last 10 years. And the last time I presented to this group, they were at the Masonic Hall, and we talked a little bit about drugs there as well. And obviously drugs have changed in that time. So what you'll see today is available to you from Evelyn. She has all of the slides that'll pop up, the slide deck, as well as the beers and the ACB list, which you'll be able to talk about later to some degree. So my focus really is on medications and how it affects care for the elderly, benevolent homicide, which is what we do when we're trying to help people with medications. We keep getting them to them until we kill them. And so let's just jump on this, see if I can make this work. Yes, so it talks a little bit about what we do, substances, psychopharmacology. I went back for a postdoc master's because being able to assess somebody is one thing. Being able to factor in how the medication they're taking affects their functioning becomes a whole other piece of business. For me, it's medical malpractice to assess somebody and not incorporate the medications and speak to that influence. For those of you who are dealing with DPOAs and conservatorship and capacity, it becomes a huge issue in baselining somebody's capacity. And if you do work in that place, then you know capacity is capacity for what? They can have capacity to manage their personal financial affairs, but lack the capacity to manage the trust, and so on and so forth. So there are various levels of it and various tests for it. If you hear somebody using the word competency, unless your patient or client is in a criminal matter, it's inappropriate. Competency has to do with the ability to stand trial. Capacity is talking about the ability to manage your daily living affairs, financial, medical, daily living, so on and so forth. I'm being redundant. So pharmacology itself, we take a look at duration and magnitude of drugs, how they affect the individual. This is stuff that will be a test on next month if they don't find a July speaker. And pharmacokinetics, this is a big piece why I threw the slide in, has to do with how we process a drug. The half-lives of some drugs, for those of you who may be into the nutrition and vitamin things, you know, if you take water solubles, they don't have any effect unless you take them a minimum of twice a day, ideally 3 times, because you need to maintain the static in your bloodstream, which is something the drug companies have never figured out. When we talk about elderly patients, though, anybody have an idea where this may impact elderly patients when we talk about this whole idea of bioavailability in the drug process?
Sedentary lifestyle?
So I had sedentary lifestyle.
Define elderly, what age are you talking about?
35 and up. All right, I'll go 40. I'll go 40. We can all agree on 40? Because now 40 is the new 20 and 70 is the new 40. So the short note on this is the rate at which you metabolize anything changes over the course of your lifespan. When we look at the drugs as they're presently certified, most of them are certified on younger populations. So they're pushing drugs, water solubles in 6 to 8 hours or 5 to 8 hours, and fat solubles, or what they call lipid coated, are every 8 to 12 hours. That's normal. So they dose that way. You look at a dosing curve, you want to keep that top and bottom of the curve relatively close together so that you don't have clock watching, which is what you see with people with significant psychiatric disturbance. They're watching the clock for the next dose. Parkinson's patients will watch the clock for the next dose because as the dose goes down, pain comes up. And then we have side effects. So I could make 2 statements, let me make one. Oftentimes when we look at the side effects in stable programs in individuals, the side effects show up. What tends to happen is the prescriber writes another drug to take care of the side effect. Or they'll try and take one away, or they'll substitute. I've yet to have somebody walk in and tell me that the prescriber did a dirty test on their metabolism and adjusted the medication directly proportional to how fast they were pushing it through their system. So if I'm 70 and my system on a water soluble is not 6 to 8, it's more like 9 to 14. It's not going to take me too long to have my chemistry hold enough residual drug if I'm dosing on a regular pattern to come up with a side effect or two. I may have increased drowsiness or agitation. I could develop certain kinds of muscular anomalies from twitches to pains and so on. And again, you walk in, you tell the doctor he or she 8 to 20 minutes tops, and they write a prescription. We call it Polaroid medicine. There you are, here you are, here. And finally you get enough here on board where you're all of a sudden losing track of appointments, you can't keep track of yourself, you're being dizzy. And again, we go back and we prescribe more drugs instead of the idea of removing them. So when I did my training, it wasn't about having the ability to write prescriptions, it was about the ability to take them away. Take them away from juveniles, take them away from adults. As you can see, there is some distortions in mentality across the board, and still there are a great many healthcare professionals who still believe they're the end-all be-all and don't like their work being questioned, number one. And number two, they won't change a colleague's work. So instead of taking the medication the patient came off with, they'll just add another one. Make sense to you? Yeah. So when I talk about pushing the drug through a bioavailability, the curve on the right is for a young guy, which is under 35, and the one on the left is for an old guy, which is over 40. And you can see that the old guy takes a lot longer to push that drug through than the younger person. And that's a benzo. And you may remember benzos if you're old enough to have seen the movie Valley of the Dolls. A couple of benzos and a martini, you're done. So a benzo, we typically say it's like a martini and a pill, or 2 martinis and a pill. Has its purpose, it comes with a lot of side effects. For instance, obviously if this guy needs a mild depressant, it's because he's a little manic, don't you think? A little excited. We use the words, it's very interesting. I was having a conversation with Ariana before the meeting about children. And all I can say is if I was a kid today, I probably wouldn't have lived past 16 for all the medications that I've been on for being a kid. Loud, obnoxious, unruly. And so now we use medications to control behavior. And that happened as a result of Reaganomics way back in the day, and a guy called Jerome Miller, who deinstitutionalized California and then moved east to wreak more havoc. His idea was good. The problem was the systems weren't in place to allow for that institutionalization, putting people in group homes and communities. And the history book is full of communities fighting to have these people in their neighborhoods. Oh, these people, oh, those, that people. So this is where Big Pharma jumped in. They came in with chlorpromazine. You may remember that. Thorazine, Trelfon, Alderol. And the mark of a good drug in those days, effective drug, is if it left the patient kind of standing there going, maybe even a little drool. That's a good drug. That's the right dose. And that's where it started. Because we're coming out of institutions that use chemical restraints, ice baths, electric shock, blah, blah. So snowballing was the term, somebody on medications, so they could be in a community setting, seemed like a hell of a lot more humane activity. But once that started, the idea of managing behavior with medications, here we are today. When I was a kid, the drugstore was like 3 aisles. Now it's like Costco. You spend all day in there buying and shopping a variety of drugs, and all of them are miracle workers. So when we talk about some of those drugs, SSRIs, some of you know about those, or norepinephrine, there's a series of drugs. In fact, I'll tell you what, I work in this all week and I can't keep up with it. Every week I get something from the FDA or something from the National Institute of Prescribers. Add this to that drug. This drug you can't use for that. Oh, there's a warning on this one now. Because in case you missed it, in the fast tracking of medications, the beta testing is being done on us. That's where the beta testing is, and that's why we're seeing the label changes. And none of the medications for anxiety and depression has ever been tested to keep people on for 5 years, 10 years, 15 years. Okay, that's all happening on us. So, this is what we probably all understand that, all right? Alcohol is one of the most dangerous drugs that we have, and it's as legal as the day is long. And in older populations who are beginning to develop some kind of brain process, alcohol expedites the process. And sometimes it's very difficult to get people to part themselves. Not 2 martinis at the end of the day. One lady said the other day, I have a glass of wine with every meal except breakfast. And so I have to start, glass, how big a glass? Half a bottle? Oh no, it was this big to start with. And she was trying to tell me she did a bottle a week. I said, oh, for crying out loud. That's like a bottle every 2 days plus. Oh, well then, only this much. It's 4 ounces. At which point you stop the debate and you just write down bottle every day and a half. And for her, that's legitimate. And she'll say that it's not bothering her. What we'll see is if she keeps that pace up beyond a point, that her functioning will fall off a lot faster than if she wasn't drinking at all. And so when we talk about functioning, let me clarify one thing. The world is having a heyday with things that will preserve your memory, keep this, do that. I told you that the lack of political correctness was East Coast and having military parents. The bulk of that is BS. We don't have anything out there that's going to preserve your memory, first of all. And second, which probably should be first, you're not losing your memory. What you're doing is losing the access to the memory. The pathways are what goes away, your ability to access what's there. If you have nothing to do on Sunday mornings, if you want to read something banal, catch up on deep brain stimulation research. And what they found, I'm sure you all read it, it's great for back pain, Twix, kids that act out. They put a couple spikes in your head, and they give a current to it, and that current is supposed to interrupt epileptic type form seizures, tardive dyskinesia, and so on. Well, since we really don't know what the hell we're doing upstairs, and every time you get to the point of going, this is what it is, somebody else comes up and goes, oh yeah, throw all that out, this is how it works now. They put the needles in, to the electrodes, and in several cases they hit an area of the brain. And here's somebody who pretty much had severe impairment, both current, which is at anterograde, and past, which is retrograde. And all of a sudden they start popping off like a dictate machine over some incident that's 25 years old, right down to the ants crawling on the floor, and the smell, and the taste, and so on. Well, if it was memory that was gone, we wouldn't get that. It's memory that can't be accessed. And that's a big difference when you talk about intellectual capacity versus cognitive functioning. 2 different things, but cognitive functioning can make your intellectual capacity look like it's diminished. And that's a whole other piece, but I wanted to try and make that as cloudy as I could. So we have the antipsychotics and the first and second degree, and the big hype was the new ones are better. You're not going to get the same side effects. People in my clinic hate when I do that, but that's the best thing I could do besides get profane. That's nonsense. They really don't have any benefit over the other ones, except the old ones are cheaper. Go out and get a prescription for Abilify or Vyonase or Geodone. It's going to cost you out the wazoo. Go find somebody who's still producing Trilofan. If you can find them, you can get it for about 80 cents a dose. It's cheap and it works. The difference is some of the families, because they're MAOIs, TCIs, these aren't political groupings, they're monoamine oxidase inhibitors, tricyclic. And they have certain effects on the body, mixing them up. When we talk about Parkinson's, and we weren't talking about it, but now we are, one of the most troublesome side effects of Parkinson's has to do with hallucinations. And most physicians don't understand that. So they put somebody on Requip, cinnamon, carbidopa, and 2 months later, the patient's back in their office and the family's going, I'm not picking on any gender here, but she keeps telling us that there's somebody running around the house, but she can't get it. When she looks, they're not there. Or this is going on, that's going on. Everybody goes, oh, she's hallucinating. Let's go take her and she's hallucinating. And then we started with the antipsychotics, as opposed to going, what's she on? A side effect for most drugs that treat Parkinsonian-like symptoms, which are tremors, is a hallucination called a presence. And the presence is something that occurs outside of the corner of the eye, or seems to be scooting along the floor. Not hallucinating, it's a side effect. And if the docs aren't up on it, now we have an antipsychotic. Olanzapine, Clonazepam people seem to love lately, and just for the record, clonazepam is a benzo. So they don't have any problem handing benzos out to 70-year-olds, but try and get one as a 40-year-old. The industry is still very conscious about not creating addiction, though it's the first-line drug for anxiety in the back channel. So atypical agents, I've talked a little about that. You know, in the symptoms they're talking about is long-term use of antipsychotics where people have facial gestures, extrapyramidal symptoms or tardive dyskinesia. The first one is reversible, the second one's not reversible. And that has to do with how the drugs impact the body and the brain specifically. Now, a lot of, I don't care what you read, they're going to tell you, this drug does this. What they're not going to tell you is, and we don't know what the hell the rest of it does. We don't know if it does this, we don't know if it does that, but here's this list of side effects. And when they started into TV, they talked like this until they got to side effects, and they were done. It was like, excuse me? And that guy does 800 words a minute, so that's not a good sign. He got 200 off there in about 15 seconds. Again, we come back to the individual bioavailability of a person. We could all take the same drug, and we might see a spectrum of responses, and then we're going to find a few of you who totally go the other way. We give you a drug to slow you down, and you're bouncing off the road. We give you a drug to speed you up, and you're falling asleep in your chair. I like to say at times, some people we can hand them the bottle, and they get better. Other people, they take the whole damn bottle, and they go, is that it? This is not working. That's the range of responders. Very seldom do you get that kind of oversight with a drug. The first place is to add something else. And or I talked about the benzodiazepines, and more of what I'm after with this side. And again, these are all available to you. Oh, that's a problem. Benzodiazepines, besides alcohol, besides neuroleptics, you may be familiar with those, more on the idea of anticonvulsant drugs. Dilantin was an old one. The neuroleptics as a whole reduce cognitive ability. Attention, concentration, memory, which is what you need to do multi-step processing called executive functioning, and so on and so forth. So those drugs already turn you down. Then throw something like a benzo or a central nervous system drug, which would be Norco, Percocet, fentanyl patches. Here's another family of drugs that makes you a little less sharp, a little dull. If any of you have taken any of this, not that any of you would for any legitimate reason or otherwise, then you would know you have a small little feeling of euphoria, which is usually about the time you're getting stupid. And depending upon how much of the drug will determine how euphoric and stupid you feel. But your response in your system is down 25%. Okay? This is not the time to go out and do something that requires quick reflexes and executive processing speed. Not the way to go. And obviously with the opiates. The fentanyls, the Oxycontin, the Percocet, the new one, which is hyperdrolgel, which is supposed to make fentanyl look like baby aspirin. It's like, how much, are you trying to kill the person or kill the baby? Because it seems to me like that's the best way to kill a person. And remember, if you're taking pain medication, what you're not doing is resolving the issue that the pain medication is targeting. All it does is turn off the volume. So if we go back to the kids, somehow or another you turned off the noise, and they were still running around tearing the house up. You just couldn't hear it until you saw something go by, window frame, door, kitchen sink. It's still going on. You don't feel the pain to it. Stimulants, we all hear about this with ADD, ADHD, narcolepsy. There's people who can go to sleep anywhere. I'm jealous of them, I swear to God. They can just go on a heartbeat. And then the rest of us who can't seem to find it, even when wrestling with cops. Well, the amphetamines, Nuvigil and Provigil, used to be the mainstay with things like narcolepsy. Now we've brought it into using it with ADHD. The quantitative thinking of MDs is, well, it's an upper, isn't it? If it's an upper, let's try it, and everything else fails. Because the way the law reads is a physician can prescribe any damn drug they want. Suppositories for nosebleeds, if they think there's a reason why it might help. Okay? When they prescribe a drug, they're supposed to tell you about the drug. Good news, bad news, what they're targeting, another drug that you could use, and the most important one, you don't have to take anything. When was the last time any of you that have a prescription medication had that protocol run on you? Exactly. There's not a hand in the room. Not one. Oh, I have 10 fingers, 10 minutes, okay. So where we're seeing the stimulants now is in treatment-resistant depression. So we have elderly folks and other folks in their 40s who aren't responding well. And I've even seen it with people with atrial fibrillation, which like freaks me out. They already have a problem with heart rate. Now we're going to give somebody a stimulant to pick up their mood. Okay, sounds good to me. Right? Oh yes. There was the woman last week who was having a problem studying and felt very anxious, had a problem sleeping, and by the time we sorted it out, she got up at 3:30 in the morning every day and studied 4 till 8 until her kids got up and consumed 8 cups of coffee. I don't think that had any contribution to it, the coffee and the sleep deprivation, but you know, it was 8 cups of coffee in 3.5 hours to stay awake and study. And she wondered why later, when she did her practice examinations, she seemed to be like a dummy. Well, exhaustion might be part of it, and then they have this thing called stage rate memory. She didn't need to drink 8 cups to go into the exam, pull it off. Okay. A lot of things go by us and we think they're mundane. So calcium channel blockers, beta blockers, these are on there because when we have the depression or the anxiety again, which is a big one, and the person is not able to hold together, what we've started to do is bottom-up management. We don't go after the neurotransmitters anymore. We turn the machine down, like in the old days, real old days. You wanted to take the car, your father went out and turned the governor down to snail's crawl. So when you had a heavy foot, it wouldn't go anywhere. Cardiac drugs, hypertension drugs, the goal is to keep your system from ramping up into a full panic attack. And that's how they manage it in some cases. Side effects are a big one, why people don't take drugs. And oftentimes physicians prescribe the drug at dose. If I really think the drug is going to be helpful, and I'm not in a life or death situation, I want to start it low and go slow, and give the person's body time to adapt to the drug, then we don't see the side effect. By the same token, if the drug isn't killing the patient, and it happens all too often, you don't just stop a drug on somebody who's been on it for 3 months, 6 months, a year, 3 years. You want to see a mess? Stop the drug. And half the time, the problem isn't that the drug doesn't stop working in 3 years. It's this. I take that blue pill every day and that does this for my attitude. So a slow, protracted taper helps us disconnect the psychology from the pill until some point the patient's going, this can't be helping me. Exactly. And then they can let go of it and we can go on from there. I've already kind of told you this, shouldn't be a surprise. So the biggest ones we see, here are some stuff by the numbers to bore you to death, and if you never understood what the hell they were writing in those charts, here's some of it. And as you can tell, having acronyms is a whole nother kind of lexicon that they charge us the big money for because we don't know what the hell they're talking about. And they don't either without the list. Okay. And it changes all the time. You think I'm kidding? Here are some sites. When I was back here, I want to tell you one thing. So the 2 most commonly misdiagnosed presentations in emergency room are low blood sugar. People show up with low blood sugar, they think they're totally stoned out or psychotic because they're slurred speech, struggle with balance. And the other one's urinary tract infection. You can buy a box of sticks, 20 tests for like $10. The #1 reason for antipsychotics in elderly who are in facilities, undetected UTIs. They start sounding psychotic and delusional, so they give them psychotics instead of pissing in a cup and giving them 6 days worth of antibiotics and they're better. As a young woman, you just cruise over. As an older person, men have it too, it can kill you. It can go from being focal to global. You become a mess very fast. So when you see a quick and rapid shift in a patient, you want to start with the basics. Urine, blood, metabolism, and then come up from there. If somebody's stable on meds and has problems, you start with what you have and you go backwards. You don't start with what you have and add to it. And so in closing, the idea I brought out about mental homicide that so irritates the AMA is this reticence to question another prescriber and change the medications when you assume the patient. If I assume your case care, I am not flying over somebody else's mindset. I'm sorry. I'll look at it, look at your symptoms. Because the big issue once you get over 65, which is middle age, becomes quality of life. What medications do you need on board? Minimal medications to manage the core conditions and ensure that the person has the highest quality of life possible. It's not sitting in a freaking wheelchair at a nurse's station with 7 other people going, until dinner time. That's not quality of life. Put yourself in the other person's position and ask yourself, what the hell do I want? What works for me? Okay, that's short and sweet. The test will be in 5 minutes. If you have questions, yeah, I'll try and entertain them. It doesn't mean answer them, but I'll try and do this.
You were going to put some websites up, remember?
Actually, Ariana, would you quick flip up one of the two slides? The websites are at the end of the presentation.
I know.
And so, but everyone has all of them, so she can send it out to the group mailing list. I told her fine.
Which one of these those PDFs did you want to see?
Both of them, just flash up one at a time. So very quickly, you're going to see two lists, and I totally forgot them. This is the anticholinergic drug, it's called ACVs. When we're assessing people for capacity in general, we look at this list for the drug on it. Any two or more takes a point off of their profile. 3 points is significant. And you'll see that there's a lot of SSRIs out there, those safe drugs. The other list is the beers list. And those of you who were here last time would have seen this list. It's been updated. The beers list of all drugs that are contraindicated in the elderly because of their ability to promote or increase the probability of cardiac or neurological events. And at least half the physicians I know have heard it and never looked at it. Yes, ma'am.
How do you feel about statins in elderly, like 80, 90-year-olds?
Again, I'll go back to quiet life and say, hyperlipidemia, hypercholesterolemia, they're an issue in themselves. They're more of an issue of hypertension. But if you're at 90 years old and your plumbing hasn't stopped yet, then I don't need 3 cholesterol drugs. A pravastatin or an atorvastatin may be fine. One there, one for hypertension, and a month's pass to the ice cream store. They're 90.
There's a lot of side effects.
There's a lot of side effects, and you'll find people 2, 3, 4 drugs deep in any area, and that's totally uncalled for. And I do have an opinion, and I share it with the docs as well as everyone else. There's nothing I'm telling you that I haven't said to them. Ready? One more.
And this may be opening a big can of worms, but what about homeopathic drugs or medications?
So complementary alternative medicines, it's not been given enough time in this culture really, because there's a fear that if we hand out vitamins, supplement B12, iron, calcium, and D, they make it better. Well, then we're screwed, huh? We don't have a prescription for those, then what would that mean? So when we talk about alternative medications, one of the sites, drugs.com, lay site or professional site. You can put your loved one's medications in and say that it'll give you all the DDX, drug-drug interactions. And you can also look for those drug-drug interactions with vitamins, foods, and so on. And that's the big thing, because sometimes mundane drugs like vitamin E, ginkgo biloba, niacin interact very badly with various series of prescription drugs. And so you don't, oftentimes when you go to the doctor, what do you take? We tell them everything is prescription. We don't tell them all the vitamins. Or in the classic case, you say, are you taking your medication? And the patient sweetly goes, yes, doctor. And if you're not an idiot, you go, are you taking them every day? And then there's this long pause. Because they knew they were coming today, so they took them today, so they didn't have to lie to you. Or you'll read them and they'll say, do you have hypercholesterolemia? No. I see you have a statin drug. Well, I take the drug, I don't have it. Okay, that's good, I got it. Okay. Kind of like people who are schizophrenic at times. When they get to feeling good, they start taking their meds, and when you process it, they go, well, I was feeling better. Okay, that's good, there's a relationship.
So almost everybody I see who's older is on an antidepressant or anti-anxiety or a combination of both. And I have a question for you. What is going on? Seriously, is just all of a sudden boost and everybody becoming depressed and anxious, or has this been a cultural issue, or has this been going on for years and we just didn't know it? But everybody's on it.
If you're asking the APA, American Psychiatric Association, we're all delusional. They have a new diagnosis for us in the DSM-5, which cuts down having to be accurate. We are all in that. But what we equate to be depression or anxiety is really adjustment to life issues. For those of you who have suffered the event of having your physicality compromised, or your intellectual functioning compromised, or your speech, you all of a sudden wake up one day and realize, hold on, I'm not in control of this body. What the hell's going on here? And there's an adjustment from that point going forward, how you think about yourself, what you're able to do in relation to people and before, and that can go on and on and on. But in depression in the elderly, a lot of times what we see is loss of a loved one that's close, or unfortunately, the older you get, the less friends you have, because they're dead. And if you're not in a situation where you have social contact, various assisted livings or all the programs, the only people you're seeing is your family. You've seen enough of them, for Christ's sake, in around 90 years. Where is everybody else? And just that little bit of socialization can make a huge part in somebody's process, I assure you. And unfortunately, the depression, just look at our world and tell me, when you take somebody's license, their world goes from here to here. It's a huge step. Yes, ma'am.
I have a question. You're giving your presentation to a very user-friendly group here today. Would you consider giving that presentation to doctors or pharmaceutical executives who need to hear what actually happens in real life?
Oh, absolutely. I put together the neuropsychology program for Alameda Hospital, spent 4 years, a whole program across the board. So I've given this in a little bit more of a vitriolic style, at grand rounds at least once a year, just so they don't get all too damn comfortable with what they're doing. Yes.
In light of the last question before this one, what do you feel about talking therapy for some of these life events that cause anxiety and depression in the elderly?
Absolutely. If you have one of the latest polls, besides Cheerios, being a Republican or Democrat, that contributes to dementia, is this idea of unremitting depression that doesn't get any better as a pathway in. But when we talk about talking early on, when we talk about Alzheimer's or anything, we don't have anything except early intervention. Somebody was saying before, we try and get in early. The earlier you get in, the greater the probability of circumvention or a less negative outcome. But that means you have to pay attention. And unfortunately, sometimes by the time family members bring their loved ones in, they are already past second base. Because as a family, we're going, oh, that's just mom. Oh, we're putting it off. We don't want to face head on what's going on. Of course, when she burnt the kitchen down for the second time, we thought, oh, maybe we should go to an electric stove. Yeah. It's a whole place. You have to recognize that everybody over 75, it's almost at 50% that we're going to have dementia. The question is it going to be vascular, frontotemporal, Alzheimer's, what? Okay. And the reason it's changing so fast, this is the first time in our history we've had so many people over the age of 60 and so many people living for so long. So the field is literally changing on the fly. Okay? Yes, ma'am.
Is there a kind of approximate percentage of MCI diagnoses becoming Alzheimer's?
Repeat the question.
Is there MCI patients or people with MCI? Is there some sort of a percentage of those folks who will become or have Alzheimer's?
So there's several pathways where somebody might get the diagnosis of minor cognitive impairment. Typically, and it can come from just medications. It's having the wrong set of medications can make you dull and dummy. That aside, it's usually an initial stage. And unfortunately for a lot of the care providers, if a physician writes dementia on that form, you can't get your loved ones into anywhere except for a memory unit. And the reality of it is, dementia is a spectrum. You can be in the dementive process down here, it's a crappy word, it's like cancer, and still be taking care of your affairs and doing business. The majority of women patients that we see in the last 5 years, they come in, because, and this is the people who have dementia don't come in, somebody brings them in. The people who, people who have it. People who don't have it, they come in thinking they have it. Those aren't the ones we worry about. But a lot of the women come in, and they want to know what's in my family, it's here, I'm doing this. I want to know where I am and where I'm going, and if I do have it, what do I have to look for? Because they want their affairs in order. It's all in order, it's all in print, it's all going forward. And half the time they don't get it. Their husbands get it, so. Women end up taking care of men 50% of the time. Okay? So, you don't have time to get prepared. They take care of us. Learn the role. Okay. Anything else? All right. Thank you very much.